Thank you everyone for being here today. Our main order of business for our board meeting this afternoon is to discuss whether to implement a program to offer 17-hydroxyprogesterone to our patients at risk for preterm birth. Here to discuss the details is Dr. Dimes.
Thank you. Hello everyone, my name is Dr. Dimes. Thank you for the opportunity to speak to you today about preterm birth. Preterm birth is a significant problem in the United States, with approximately 1 in 10 babies being born prematurely. As you can see from this map, there is a geographic distribution, with patients in the southeast regions having the highest risk of preterm birth. However, you can see that uniformly throughout the United States, this is an issue. We know that patients that are at the highest risk of preterm birth are those that have previously had a preterm delivery. However, we do have strategies to help decrease the risk of preterm birth with our patients, one of them being the administration of 17-hydroxyprogesterone. This medication is administered on a weekly basis. It's an IM injection that's given to patients between the weeks of 16 and 36 weeks gestation. Patients who are considered to be candidates for this medication have a singleton pregnancy currently and have previously had a spontaneous birth before 37 weeks. There's a lot of data surrounding the use of progesterone for decreasing the risk of preterm birth. And as you can see here, in patients that receive progesterone versus a placebo, they reduce their risk of delivering before 37 weeks by 34%. And when we stratify this out with different delivery timelines, you can see that the risk of delivering before 35 weeks was reduced by 33%, and the risk of delivery before 32 weeks was reduced by 42%. And this may be even the most important number because these neonates are in the NICU for much longer with much higher intervention and cost. Similarly, progesterone can be used to decrease the need for O2 supplementation. This reduced risk was 38%. It reduces the risk of intraventricular hemorrhage and necrotizing enterocolitis. And lastly, we know that patients that have various social circumstances such as poor access to care, decreased nutrition, homelessness, poor health literacy have higher risks of preterm birth, and this is our patient population. So even more so, I think implementation of 17-hydroxyprogesterone in our patients would reduce our preterm birth rate. This is considered a standard of care medication, and it's something that I strongly feel that we should be giving to our patients. Thank you.
Thank you, Dr. Dimes. Next, we'll hear from our Chief Financial Officer to discuss the financial impact on our clinic with this program.
Thank you again for your time, Dr. Dimes. This certainly sounds like a very promising intervention, but I am very worried about the financial costs it'll have on our budget and, quite frankly, our ability to keep our doors open. As I'm sure you're aware, this is a very expensive medication. It's available in its FDA-approved branded form from only one company and costs roughly $690 per injection. We also estimate an additional cost of roughly $120 for administrative and clinical fees. And this includes covering the cost of nursing, administration fees of the medication, pharmacy, storage, and restocking fees. At 20 doses per pregnancy, we estimate that this will cost us roughly $16,200 for the 20 doses.
Thank you very much for your presentation as well. This is certainly a very important topic, which is why we have brought it for full board review. This is certainly a very costly venture, but may be worth it considering the cost to the health system with even one preterm birth. On the other hand, it's important to remember that we are considering it in the context of our other competing programs. If we fund this program, we would have to delay funding for our centering group prenatal program, which we had initially wanted to roll out this fiscal year, and itself has been shown to reduce the risk of preterm birth in high-risk populations such as our patients. We would also need to defer the transitional home health program, which was set up to help postpartum moms with breastfeeding. I think the next best step is a cost-effectiveness analysis to better understand this problem and how we should address it.